And so, Lynn, why don't you take it away? And thanks for the three of you for doing this. We appreciate it. So,
Thank you and welcome everyone to our Wednesday event for one of the events for our week of health sciences. And I have three great professors to introduce to you to share their work. I'm going to start. My name is Dr. Lynn Longton. I'm the chair of graduate nursing, and I teach primarily in the nurse practitioner program. And the first person that's going to speak is Dr. Natalie Stepanian, and she teaches in our D&P in our graduate and undergraduate programs. So she wears a lot of hats and has a lot of knowledge to share. And we're proud to have her here today. And I would like to have her present the work that she's working on right now. Thank you.
Thank you, Lynn. I really appreciate it. And hopefully you'll find this, this presentation interesting. I'm going to go ahead and share my screen. And I can share with you one of the current projects we're working on. Can you see that okay? Okay.
Let me just interject. If anyone has trouble with their technology, please just sign off and sign back on. If there's any glitches or we freeze or anything, well, hopefully everything will work fine, but I just wanted to give people that information. Thank you.
So I'm just going to give a quick blurb about the background of how this all started. We were working together with a group, and as you can notice, Joanne Joseph's name is on here. And she has a very creative way of bringing people together. So we were working and had a great interest in this particular topic about older adults and perception of climate change. We're doing a collaborative effort with between SUNY Poly and also SUNY Oneonta. And it's also an interdisciplinary group. We have nurses, we have sociologists, and we have psychologists. So it's actually very interesting that we came together on this topic area. And it's specifically about New York State. Right now, our hope is to broaden that to other geographic areas and look at those as well. So let me go ahead and just. So we know that currently the temperature trends, and you will hear me call that weather pattern changes as opposed to the political trigger words of climate change. I try to avoid it, and maybe I shouldn't, but I'm not so sure. Depends on who you talk to. So over the years, we've had this climate pattern change, and anybody that's from upstate New York or lived in New York State in itself has seen this happening over the years. We've seen pattern changes like when we were small and growing up in the 60s and 70s, and I'll go ahead and say 80s because not everybody's as old as I am, but there's been a big change in those in the pattern, the amount of snow that we get. The growing seasons have really elongated so that it's very different than it used to be. The opportunity for different pattern changes with the weather, for instance, and I'll go ahead and we'll talk about it as I go into this further. So we know this climate change is happening. It's having an impact, not just weather, but also opportunity for vector-borne diseases that at one point never existed here, but now the climates are going to be conducive of these vectors being able to survive here. Again, how this extreme weather pattern changes can impact both physical and mental health for the individuals that are exposed to them. And we really don't know at this point. There's not been many studies that have even looked at this. So our age bracket for this particular qualitative study was to focus on older adults or people who had lived here probably since the 80s. So they're really focusing on that group because they would have been able to see a lot of these changes. You can take a look at this particular diagram that shows you the different temperature changes and that projected annual change in the 21st century. And we see that it's really changing within not only just in central New York, but even up into the Adirondacks and places like that. So the purpose of the study is to ascertain the perceptions of the older adults on climate change, and then we're going to correlate the perceptions with actual climate data since the 1980s and inform future educational and policy efforts related to those climate changes. Methodologies, we're going to look specifically again at that age 60, around age 60 years of age that have lived here for over the last 20 or 30 years. We're going to use an inductive approach, and we've already conducted the semi-structured interviews using an interview guide. We've had data collecting both at the SUNY Oneonta area and also in the Utica area. They're recorded and they've been transcribed, and now we're in the analysis portion using grounded theory. So this is just an overview of inductive approach. You're really looking at observations and maybe some testing and looking through the data to look at patterns and coming up with theories. So hopefully this will lead to qualitative studies. We're already looking at measurement tools that are out there for the next step of this to really look at that impact that it has, again, on mental and physical health. One of the things that's very interesting to me, and I'm going to go into this a little bit, is, and I recently have written a paper that's going to be published in the American Nurses Association Nurse Practitioner Journal, specifically about a vector-borne disease that's climbing or actually creeping up the eastern seaboard. And you recently heard in the news that there was a guy from New Jersey that died from what we'll talk about, which is alpha-gal. And hopefully a lot of this will not only help us to educate our populations, but also can work towards policy changes. So one of the things that I'm going to delve into is this particular little vector who doesn't. Anyway, I pulled the picture from CDC, and it really shows this particular tick. I'm going to call it the Lone Star tick because Amblio americana is the actual name, and I'm probably pronouncing it wrong, but it's classic. It's very tiny. It's about the size of a sesame seed. In prior years, of the last 20 years, this particular tick was indigenous to the Americas, and it was primarily located in the Virginia area and the northern North Carolina area, but it has since been creeping up the eastern seaboard, up into not only New York, but New England and up into Canada. This tick, the temperature range that it can live is now habitable here in New York. There have been now discovered just down in the area of down by Long Island, they've had over 3,000, almost 4,000 cases of confirmed alpha-gal syndrome, which is really what happens is the tick will bite you. It'll inject a carbohydrate, which is the short term for it is alpha-gal, and your body will react similarly to proteins that get injected. It will go ahead and build up antibodies towards it. Many people can develop allergy or allergic reaction to mammalian meat, mammalian products, including cheese and yogurt and any of those sorts of things. There are many medications that have the alpha-gal in it, so you end up building up antibodies. So certain chemotherapies, certain unfractionated heparin, all sorts of things in the medical field, including like bovine or any porcine, like, so maybe it's a heart valves that are being implanted, or anything that contains that. So it's becoming really critical that healthcare providers understand this and learn about alpha-gal, because it needs to be on your radar when a patient comes in with weird, maybe just GI symptoms. They eat a hamburger, and this is what happened to the guy in New Jersey. He ate a hamburger, but by the time the evening came, he had died because he went into full-blown anaphylaxis. It can be a lifelong allergy after that. So these guys, or men and women, can no longer go out and have a hamburger. They can't have a steak. It affects people that are out in these environments. So people that have jobs that are outdoors, hunters, people that spend a lot of time hunting. Um, how sad would it be to be able to, a hunter going and getting a deer and then not being able to eat it? So it's like, it really is impactful. And because it's growing in this area and emerging, most of the healthcare providers are unaware of it. So this little tick has this white spot on its back. The female is more pronounced than the male. The male actually has the white pattern on the border of the back of its shell. They're very tiny. And I think, now most of you that live in this area understand that back in the day, there were no ticks, or if there were very few. As a child, I used to run the fields and I was, active outdoors all the time on my grandparents' farm. We never got ticks at all. Here, now, just walking my dog, I'm getting ticks on me. So again, the changes in weather are critical. New York State it would be unheard of to have a tornado in this state back in the day. Now there's up to 24 to 26 annually, and it's really impacting. And so we're trying to look at those things, and how can we help individuals be able to protect themselves and to be able to, come to terms with these weather pattern changes, maybe help with their, preparing at some level. So that's really it. This is what we're looking at and what we're studying. Are there any questions for me? All right, no questions.
I have a question. Hi,
Yay.
Natalie. Thank
Hi,
you.
Nick.
So, did the in your study, did you see that people were highlighting the Lyme disease and the tick as a main concern?
Well, this particular tick, the Lone Star tick, is relatively new in this area. We've already had cases in Utica that I've heard about already, and the primary region that they're mostly now is down in Suffolk County. That's where I'm
Yeah.
talking about almost 4,000 cases of documented alpha-gal syndrome. And that includes a wide range of this allergic type reaction. Many people just get GI symptoms initially. And like with any allergy, it progresses. So, you might start out with just a little GI upset, but then it will progress into a full-blown anaphylaxis reaction. And I think it takes people off guard because they don't expect it. But I mean, the guy down in New Jersey just came out in I think it's the last week, that, I think he was relatively young. I think maybe 45, 50-ish years old, had a hamburger, went home, and then died. I mean, that was the end
So this is
result with him.
this is an addition to Lyme disease, right? This alpha-gal syndrome,
Oh
because
yeah, completely different tick.
yeah.
And it's just, like I said, the environment is more conducive. Our temperatures are higher, the growing season's longer, and they've got lots of places to hide. And they're thriving up here.
Natalie,
think-
I don't know if you mentioned this already. I must have missed it. Where did this tick originally come from? Was it more of a southern one that's just coming upward, or
Yeah. It started out in the Virginia and the northern North Carolina area. People think because they call it Lone Star tick that it comes from Texas, but that's not true. It started in those areas, and the phenomena started happening there. I actually have friends that have it, that can no longer eat mammalian meat. They're only fish and fowl. That's it, for protein. And it can be devastating to people. And I think that when you think about it, you know, I always think about like little kids, or people that are unsuspecting, older folks that just have no idea. And if they start with mild symptoms, knowing what to do. And so creating awareness, and, especially among our healthcare providers, so they understand this, In Virginia, the University of Virginia has taken on one of the biggest levels of actually doing the research on it. And I knew this because living in Virginia, so I was very, acutely aware of it. But the fact that it's creeping up here is kind of really scary.
Well, and that's the issue. My sister-in-law, she lives in Minnesota, and she was ultimately diagnosed with Lyme disease. But
Yeah.
this was before. Now it's very common for a PCP to figure out, okay, this might be Lyme disease.
Mhm.
But she went through 10 years of all these tests, wondering what's wrong with me. And
Yeah.
the Lyme disease was the furthest thing from their mind. And so I imagine the same thing here. These people come in with symptoms, uh, they're trying to figure out what the issue is, and they wouldn't even think of that lone tick or lone star tick being an impact. So.
No, I think the biggest thing for me is that you think about this tick, it's so tiny, sesame seed, so that's tiny. Half of the people, and especially older populations, they probably won't even know that they got bit by them.
Yeah.
Or you get a patient that comes in and they give the medication to them. So say if they're going into surgery, unfractionated heparin, all of a sudden your patient goes into anaphylaxis. Well, why?
Mhm.
Because of this issue with alpha gal. So and not only that, you think about gelatin and how many products have gelatin in it, especially in the medical field.
Yeah.
So you think about that and you're giving your patient these medications and you can't figure out what this is coming from. And so the biggest deal is to be aware, spread the news to, the populations up here. And I think make sure you keep it on your radar so that you actually do a test so you can test their IgE levels for alpha gal. And then you have to do all of the teaching, and so people understand what they can and cannot do with it. So
Thank
one more happy thing, right?
Yeah. Thank you, Natalie. I definitely
You're
will
welcome.
get the word out to providers and people because I think it's important for
Well, I
providers to put this in their differentials.
the article that I just wrote about the alpha gal is going to be coming out in the next couple months, I believe.
Great.
So
Wonderful.
that'll be available too.
Thank you.
Thank you.
Okay, next is Dr. Christina DeJock, and she will be presenting work that she's presently involved in. So take it away, Christina.
Thank you so much. And Natalie, if you don't want to have an echo, you have to mute your computer and just listen to me.
Okay.
Sorry, it's hold on, I'm going to get there. Okay. Share. Okay, so is it in the presentation? Can you see it?
Yes, we can see it.
Okay, so this is a presentation about, we compared in the study SCID-5, which is the structured clinical interview from DSM-5 to a self-administered tool. So this study was done in the context of mental health of nurses. This is a portion of a bigger study. Nurses, particularly post-COVID and during COVID, suffer from more mental disorders than the general population. And here, when we are focusing on the major depressive disorder, first, it's one of the most common disorders in the United States. But when you compare nurses, so you have nurses, 22% of nurses suffered from mental disorder, from depression, compared to 8.3% in the general population. So nurses are at higher risk for depression than the general population, particularly when you look at the multiple challenges that RNs face in their jobs. Our jobs in the hospitals, particularly because that concerns RNs in the hospitals, our jobs are much demanding, stressful, And so there is higher risk for depression than in general population. And also there is evidence that when nurses suffer from major depressive disorder, there is a higher probability of making medical errors. So it can have far-reaching consequences. The idea is that nurses separately, differently from the general population, can benefit from screening for major depressive disorder. So what we wanted to check here was to compare how taking a self-report measure versus a clinical interviews, how good was those self-report measures were versus clinical interview to detect or at least show a suspicion of mental depression in nurses. So the purpose of this pilot study, because it was a pilot study, was to compare the identification of depressive symptoms among nurses with a self-administered screening tool versus a clinician guided psychiatric interview. So we enrolled 25 nurses for this pilot study. The nurses were from a large hospital system in New York City and the area of New York City. This was a self-identified enrollment, which means nurses decided to enroll. The inclusion and exclusion criteria were the following. Inclusion criteria, well, the nurses couldn't be pregnant. They had to be working for the hospital for at least a year. And they had to be able to read and talk, respond in English language. And the exclusion criteria, well, the opposite of those inclusion criteria. So we got 25 nurses, and the nurses first, they had to fill out the back depression inventory too. For those of you who are not familiar with back depression inventory, it's a 21-item self-report questionnaire that uses this ordinal response scale 0 to 2, 0 to 3. And it's very, very consistent. It has very high reliability, which means it's really measures. The items are well related to each other. And we compare the back depression inventory asks questions about how people were feeling for the past 2 weeks. When the structure of clinical interview for DSM-5, there are 2 versions. One is a clinical version and one is a research version. And research version is more comprehensive than the clinical version. So we use the research version. The clinical interview was run by a psychiatric mental health nurse practitioner, by me. I was part of that study. That was my job in the study, was to interview all the participants. And the clinical interview has a decision tree. You ask the questions. The options were 1 to 3. 1, the respondent denied. 2 is kind of like being on a threshold, and 3 endorsed the symptom. So the result here is that according to this SCID-5, that's a dichotomous, no. The patient, the participant either has the disorder or doesn't have. There is no gradation here. There is no like mild, moderate, severe. It's yes or no. So similar for the back depression inventory, we divided into yes or no using a cutoff point. So the BDI-2 was administered using Qualtrics electronic survey, and the SCID-5 I administered over the Zoom video. The SCID-5 can last from, I think the shortest interview I conducted for this study was 15 minutes. It can last up to 2.5 hours. The longest I had was 1.5 hours. So we use the scores from BDI-2 and the dichotomized scores from BDI-2 and the SCID-5 codes that are dichotomized. Per definition, this is how the SCID-5 works. And we use the Pearson correlations to determine if there was correlation between the results on the BDI-2 and on the SCID-5. So those were our participants. The mean age was 45 years old. The majority of our participants was white and female. Most of them were married. Most of them, their highest degree was bachelor in nursing, and they had mean number of years of experience 18, with you have here the standard deviation. So the BDI-2 identified 11 respondents, so 44% are screening positive for depression, and SCID-5 identified 11 different respondents. So there was some overlap between the correlation between the BDI-2 and SCID-5, and it was 75%. So BDI-2 misidentified 3 of the respondents as screening negative for MDD, while these respondents were diagnosed with MDD during the SCID-5 clinical interview. So to explain that, that correlation, that's not 100, that's not 1, you see, the BDI-2 asked about the past 2 weeks of how people were feeling, while the SCID-5 explores also past episodes of depression. So somebody could be positive for depression because they had history of depression on SCID-5, why they had no way would respond negatively on BDI-2. And also, some people could have had history of MDD, but being treated, so they would deny the depressive symptoms on the BDI-2. And also, there was some time lapse between the day when people fill out the self-assessment questionnaires and the time when actually they were interviewed. So there was this moderate coloration. The advantage of BDI-2 comparatively to SCID-5 is that BDI-2 is easy to administer, it's cheap, it's reliable, it's a good screening tool. So when SCID-5, it's time consuming and it requires training, and to be trained to actually use SCID-5, it's a minimum of 6 hours of training. And that was for me being already a mental health professional. So for someone who doesn't have that background, the training would be more time consuming. And of course, you have to pay somebody who is administering a clinical interview. So we concluded that if we were screening for major depressive disorder, there was a need for a multi-assessment in practice and in research. In research, our next step here will be to enroll. We are in a process of enrolling 100 participants in a much larger study, where again, I will be running the SCID-5. I already started running the SCID-5 interviews, and the participants will be responding to back depression inventory number 2 via Qualtrics. So in this particular study, neither the BDI-2 nor SCID-5 were superior in identifying major depressive disorder in respondents. So thank you so much for your attention. Any questions?
Christina, I'm sorry. Christina, are you going to be using the same type of population in your larger study?
Yes. So the larger population here, it's also the same hospitals, because it's a large hospital. So here, because it's not a publication, I can tell you it's the New York Presbyterian system, which has hospitals in New York City, in Westchester, and Mid-Hudson. So this is where we are looking for nurses. It's self-enrollment, so the potential participants get emails from the education department, and then they reach out to my colleague. This is a study between Columbia University and me representing SUNY Poly, but it's more than Columbia University because there is also people from Montefiore. Psychologists from Montefiore are involved. So we are enrolling 100 participants for a larger study here.
Great, thank you.
And this particular study that I'm presenting to you here, it was run, it took place in the fall of 23. So exactly 2 years ago, I was interviewing the participants 2 years ago in the fall semester.
Great. It sounds exciting to get more
It
information.
is very exciting because
Yeah.
you see the way it works. We first did that pilot study, which was the 25 participants, to see the feasibility. And then now we have a larger study, and with the results of the larger study, we can go and apply for R1, which is like, you know, the ultimate goal, and then go for a much larger study that goes beyond New York City, New York State.
Yeah.
That's the goal. We'll see how it works. But that's,
Great.
you know, these steps here.
Good work. Thank you. Any other questions? Okay.
I have
thank
a
you,
question from me.
Go ahead.
Hi.
Hi, Nick.
Thanks, Christina, for that. It's very interesting. I'm wondering a little bit about, so I think you want to identify if some aspect of the nursing practice is causing the depression symptoms.
Oh,
That's
it's
a
an
part of the
excellent
question,
question,
or
Nick. It's a
sorry?
part of the, it's excellent question, Nick.
But
Thank you
just to
for
add, so
asking
just to add,
it.
because a comment too to that question is because I was also thinking that I'm wondering if just so how are you going to identify that causal factor? And I'm wondering if people that are maybe more susceptible to depression may go into nursing
So
because they have uh,
yeah, no,
uh
I get it. I get
yeah.
it. You see, what we are doing is I'm presenting the part of the study on which I was actually focusing. I was, you know, I was running those SCID 5 interviews. So I compared the SCID 5 interviews with the actual back responses. But that was much larger study. We got more data. So first of all, the participants were given a Somni kit, which was something that was supposed to help people sleep. The Somni kit, it was given to us by people who were interested in, you know, having a study if the Somni kit works or doesn't work. So we were asking about, you know, how much the use of it. The Somni kit included like a mask, I know there was a lavender spray and all, and I don't remember exactly more, but there were several things that could help people sleep because we presented this study as sleep study. We also checked the participants were wearing Oura rings that were checking their heart rate and really assessed in an objective manner from the, you know, physiological perspective. It assessed their sleep patterns, how many hours they actually slept. And they also responded to more than, you know, back depression inventory. They responded to the perceived stress. They responded to a questionnaire that described the work environment. And they also, so to assess, you know, if there were anything in the work environment that was correlated with any of the, you know, and depressive or stress symptoms. And they also fill out the questionnaire on a very common, popular in this field, much like a burnt out inventory. So we correlated those results. So this is just a small portion of a bigger study. So we check if there was like any correlation between major depressive disorder as identified by those two tools with the perceived stress, with the work shift, because night shift, day shift, perceived stress at work, perceived stress at support at work, because, you know, this work environment, the work environment questionnaire is composed from a few subsections, and one section asks about the leadership. Is the leadership supportive, not supportive, the conflicts at work, the cooperation with other professions. So we explored all those correlations among you know, various aspects. Do we know if there was any strong correlation? Yes, some of those correlations were surprising. Like, for example, nurses who responded that they perceived more stress at work, discrimination on that work environment questionnaire, they actually responded that they were less stressed on mass like burnt out inventory. So, but again, the sample was small, 25 participants. So it's reached what we know. It's feasible, but we explore other aspects, not just depression and back inventory and SCID 5. But thank you so much for asking that question.
Thank you, Christina.
Any other questions? Okay, thank you, Christina. Nice work. Thank you.
Thank you.
Next, we have Dr. Patricia Roach. She is presenting as well. She is the coordinator of the Psych Nurse Practitioner Program. And she has done some work too that is exciting. So she's going to be sharing that with us.
Thank you. Thank you, Lynn. Today, I want to talk about our study, COVID-19 Pandemic Worries and Academic Resilience in Adolescents. And this was interdisciplinary collaboration with Doctors Joanne Joseph, Jerome Neri-Rora, and Robin Jacobs. Okay, so what we wanted to do was examine how COVID-19 related worries affected academic resilience in adolescents. We wanted to test whether depression, social protective factors, and adverse experiences mediated the relationship between COVID-19 related worries and academic resilience. And as part of that, our definition of resilience was adopted largely from Mastin and Cicchetti's 2018 definition, which was resilience is the ability to adapt positively in response to stressors. Furthermore, we wanted to look at academic resilience, and we used Yi et al.'s definition and modified it slightly to fit our model here. And in this academic resilience, this definition differs from the traditional view in that they define that as the student's ability to perform highly despite a disadvantaged background. And what we changed it to was that academic resilience is the ability to continue learning despite disruptions to the learning environment during and after the pandemic. And that was necessary because we all know during that period of time, especially in New York State, our youth were off learning online for about a year and a half. And then we looked at the influence by risk factors and protective factors, specifically adverse childhood experiences and depression, and then the protective factors of family, peers, and school. Our problem statement was that pandemic worries increased distress in academic challenges. And we initially thought we'd see more along the lines of anxiety. And as you'll see as I go through the study, depression turned out to be the bigger problem with, impacting academic resilience. We looked at academic resilience in K-12 students because that had remained unexplored. And we also included demographics such as gender and LGBTQ status and wondered how they may influence the outcomes. Our purpose and objectives, we're going to examine direct and indirect effects of COVID-19 worries on academic resilience. We were testing serial mediation, and those models looked at adverse experiences, social protective factors, and depression. And I'll explain more about that in a bit. Again, the age, gender, and LGBTQ differences. And what our hope or our aim of this was to inform school-based and public mental health interventions. The predictor in the model is, I'm going to move right to that model so you can see that. And so in this model, this serial mediation model is based off of Hayes's model 6. And I will say that this is Dr. Neri-Rora's expertise here. We examined how adverse experiences, social protective factors, and depression mediate the relationship between pandemic worries and academic resilience. The arrows represent hypothesized pathways and illustrated both direct and indirect influences. So the direct path there suggests a direct effect of pandemic worries on academic resilience, while the indirect paths capture the mediation through multiple variables. This design enabled the estimation of total and specific indirect effect, and it offers insight into the complex interplay of factors shaping academic resilience. So this was a cross-sectional survey done April to May of 2022. These were central New York. This was specific to Oneida County, and these were students in the grades 7, 9, and 11. Initially, we started out with over 3,000 respondents. There were 3,300 or so, but we did need to exclude some for incomplete data. So we ended up with 2,584 adolescents. This was reviewed by SUNY Poly's IRB and was deemed exempt. Our demographic breakdown, gender, we saw 48.6% male, 46.5% female, and then 4.9% described themselves as other. In those belonging to the LGBTQ community, 18.1% self-identified with that community, and 85% English was their primary language. So our survey measures, we used a tool, Pandemic Worries, 8 items. It was a 5-point scale. Academic Resilience, 4 items, 4-point scale. And then depression, there were 6 items in there. The social protective factors were coded yes or no due to the complexity there. Adverse experiences, there were 3 binary items, and then there were controls. Again, this is Dr. Neryova's expertise. Controls were age, gender, and LGBTQ and language. And that's the analytic approach, Hayes Process Model 6, SPSS 29, SEM bootstrapping, 5,000 samples, and then it was again controlled. So what did we find? Our results were interesting. Pandemic worries, again, we were expecting to see more along the lines of anxiety. And you can see some of that there with friends and family getting sick at 57%, feeling lonely at 50%, which really played into the depression model. Financial and emotional concerns were moderate, and you can see the sensitivity there. Our challenges, according to these students for academic resilience, 49% struggled with online transition. Some of that was related to, getting computers or getting online, or being the ability to sit in a quiet place to learn. 51% said school was harder, and 50% had trouble accessing help. Now remember, this was in 2022 at the height of the pandemic. 61% felt tired often, 54% had changes in sleep and appetite, and 52% felt more worried, and 40% had lost interest in their usual activities. These were our depression results here. Adverse experiences, these were the reported experiences, cyberbullying, dating abuse, and then sexual coercion. The social protective factors, on the other hand, 95% felt safe at home, 84% felt they can confide in a parent, and 87% in friend. And here are our responses to social protective factor questions. In a typical week, all my family members eat a meal together at least 5 times. My parent guardian knows what I'm doing when I'm not with them after school or out with friends. So there was this sense of closeness with the parent. I felt safe at school. I can turn to my parent or guardian if I have a serious personal problem or need to talk to someone. So again, that closeness with the parent. And I can turn to my friends if I have serious personal problem or need someone to talk with. And I feel safe at home. So safe at school and safe at home. The strongest path in the mediation results was pandemic worries, depression, and academic resilience. We did see some buffering modestly with social support. However, depression, well, let me get into those right here. Our key paths, more depressed, less academic resilience. higher social protection, better academic resilience. Those that identified it belonging to the LGBTQ community had higher depression reports, self-report, higher adversity reports, and lower sense of protection, social protective factors. In the only difference we saw in gender was in males, we had a lower depression reports. So the implications for school in practice, obviously to screen for depressive symptoms post-disruption. So this was our first pandemic in my lifetime anyway. And if we were to go to another online forced learning situation, we would want to have a better method to screen for depression. Strengthen family, school, and peer connectedness. That was shown in our mediation results. Build identity affirming supports for LGBTQ students, not only during pandemic, but we think that that can go beyond this academic resilience look. Teach adaptation between online and in-person learning. I think that given the experience these students have had going forward, that's definitely going to be something we want. You know, there's talk instead of perhaps snow days, that kids would switch to online, which would keep us adept at that. And then disseminate coping strategies through public channels. And we felt like there was some of that done during that time period, but this was our key takeaway. Limitations, this was cross-sectional, no causal inference. There were limited ACE measurements, only 3 items. This was a single county sample, and there was no qualitative context for the lived experience. And in conclusion, pandemic worries undermined academic resilience. Depression was the central mediating factor, and not anxiety as we originally had hypothesized. Social supports helped, but were uneven. LGBTQ students were more vulnerable, and schools should integrate mental health into academic recovery going forward. Are there questions for us? For me, but I will try to answer for Jerome. Otherwise, I will send it back to Jerome on that mediation analysis piece.
Yeah, that was my question. The mediation, the model, the statistics, what he did. So I have to ask Jerome, right?
Yes, I would not be your expert in that area. Nick maybe could
Yeah.
help us in with some of that, as he'd seen. I don't know if he's seen that data, but
Were there any
haven't seen that data, but go ahead, sorry.
I was just wondering, well, you can finish, Nick. I'll go because it's a new question. So go ahead, Nick.
No, I haven't really seen that data, but yeah, mediation is essentially correlation. So
I
it's there are
understand
different
the
ways to do correlation
mediation.
between different variables, one first and then the other, and seeing if you know, it's correlated with some and not with others, and then we can kind of infer if one is mediating the other.
That I'm not familiar with the model that Pat mentioned here. Which statistical model was used? Mediation, yes, I know what mediation is. But anyway, move on. I like to see more numbers. You know, I'm a number person.
oh, well, we'll be happy to get you a full copy of the article. The good news is we are now under peer review with a Springer publication. So we're really excited about getting this paper published in the coming months.
Great. I was just wondering if there was any surprises. I heard you mention that you were thinking anxiety, but you got depression as a response, you know, common response. Were there any other surprises, anything that you were not expecting?
No, we really went into this thinking anxiety and the fear of getting sick and the fear of their parents getting sick. And I guess that's what happens when you look at it from our perspective with the youth. We always say, you know, they feel like they're superhuman and they're not going to get sick. There was some fear about family members getting sick, though, and that rang true.
But I guess with that age group, they're more socially connected to their peers. So that's probably what caused some of that depression, is that exile from all their friends for such a long period.
Absolutely. Yes, they couldn't play sports. They couldn't be in their clubs or activities. And that really, that social isolation was a huge piece in this.
Yeah, so it kind of makes sense. Yeah. Great, good work. Any other questions? I think we had some fabulous presentations. Thank you all. I was very proud to be
Thank
able to
you.
highlight some of the work that everyone's doing here in the School of Nursing. We're lucky to have such talented individuals. I do have an evaluation tool, which for some reason I couldn't get into the Zoom, so I will email it to each of you right now so we don't forget. And if you could please fill that out, that will help us as we plan for future presentations. Thank you for your time and attention, and thank you presenters for
Yeah.
your great work.
Nice
Have
job, Pat, Christina, Natalie. Thanks, Lynn, for hosting this. Our next presentation is tonight at 5 o'clock. Jackie Montgomery, who is the Director of Nursing, will be talking about nursing as it moves into the middle of the 20th or 21st century, which is not that far away. So thanks, appreciate it. Thanks for everyone showing up.
Thank you for having us. Have a nice afternoon. Bye-bye.
Bye-bye.
Thank you.